Hey, Dave with Align Therapy here. I wanted to talk about how to determine if your child needs treatment for their scoliosis. At Align Therapy, when I'm evaluating patients for treatment, it's a common question, which curves need to be treated, which curves don't need to be treated. And it's a really good question. It's a really complex question as well. And if we knew exactly who was going to progress and who was not going to progress, then we would be able to determine the need for treatment a lot easier. But without a time machine or a crystal ball or something like that, we don't know exactly who is going to get worse and who is going to have pain in the future and who isn't going to get worse. Chances are, maybe a 50-50 chance that it's going to get worse or that it's going to stay the same. But we don't know who those patients are. And so we use some things to try and give us a clue into who needs to be treated, who has a risk of progression, and who does not. So the way I think of it is in four ways. One is that we need to look at the age of the person at diagnosis. And we'll talk a little bit more about that. We need to look at their growth potential, so how much growth they have left. We need to look at the Cobb angle at diagnosis. And then we also look at family history. Family history isn't the most reliable of ways to look at what the curve magnitude is going to be, but we still need to think about that. So hopefully this is helpful as we talk through this. Don't forget to subscribe to the channel and leave any comments that you have about what we talk about, because you might have a specific situation that you want to ask about. So the first thing, age at diagnosis. So typically the younger someone is when they're diagnosed with scoliosis, the worse the prognosis, or the larger the curve is going to be, or the more risk of progression they have. So someone that's diagnosed at 9 years old has a higher risk of progression than someone who is diagnosed at 14 years old. They just have more time to grow, unless that diagnosis was missed and they actually had a curve at 9 years old but they were caught at 14 years old. That's a possibility. But when they're diagnosed, if they're younger, they have more time, more risk of progression. So we have to take that into account. The other thing that we have to look at is growth potential. So their growth potential means how much potential growth they have. So that kind of goes along with age as well, but we usually look at growth potential with a Risser score or with a Sanders scale. So a Risser score is looking at the pelvis, the growth plates on the pelvis. It's a 0 to 5 point scale. 0 is they're not done growing. Well, they haven't started, their growth plates haven't started to close, and the 5 on the Risser score is that they're pretty much skeletally mature. Sanders scale is a little different scale, and we can look at if someone has a fair amount of growth left or if they don't, based on their Risser or their Sanders. The Sanders score, you have to do a hand x-ray, so it's not immediately in a scoliosis x-ray, so it's sometimes a little harder to get. But if you have access to the Sanders score, that's the way we look at it. If they have more potential growth, then they have a higher risk of progression of the curve. It's just they have more time to grow. Especially if they haven't hit their peak velocity of growth. That peak velocity of growth is when we see the most progression of scoliosis. So look at their growth potential. More growth potential means more risk of progression. And the first thing, age at diagnosis, the younger they are, the higher the risk of progression. The third thing is looking at the Cobb angle at diagnosis. So there's a very big difference in risk of progression from someone who has a 10-degree scoliosis at their diagnosis and someone who has a 40-degree scoliosis at their diagnosis. The higher the Cobb angle, the higher the risk of progression. So you have to take that definitely into account. Someone who has an 11-degree curve probably doesn't need as much treatment unless they are younger. So we start to combine these to figure that out. The fourth thing is looking at family history. It's not uncommon for me when I'm talking to patients to find out that their mom has scoliosis and it progressed to 45 degrees. Their grandma had surgery for scoliosis when she was a teenager. Their sister has scoliosis, and it's in the 40s, we can look at family history to see how progressive that curve is. It's not always the same, but it tends to track fairly well with those bigger curves. You know, if it's a consistent thing in the family where these curves are getting bigger, there's a higher risk of progression. It's not a perfect system, and there's not a specific scale to look at with that, but it's something that you want to look at. So the way we combine these, so those are the 4 things. The way we combine these is we look at the person and we use all 4 of those things to see what risk of progression that person has. So for example, if we have someone who's 9 years old and they're diagnosed with a 15-degree scoliosis curve, and they have no family history of scoliosis, their age puts them at a higher risk of progression because they're 9, they have more time. They have a smaller curve at diagnosis, which doesn't have a higher risk of progression, and they don't have a family history of a progressive curve. So that person has a mild risk of progression. It's something that we want to watch, but we may not go way aggressive at treating that because they don't have that big of a curve at that point. So let's do a different one. A 12-year-old who has a 40-degree curve and their Risser score is a 1. The Risser tells us that we have more growth potential, so we want to treat because of that. The Cobb Angle is bigger, so at diagnosis, so we want to treat that as well. And maybe they have a family history with scoliosis. So we have to look at each of those things. There are some things that make this complex though. So if we have people that are kind of on the border, so let's say we have a 15-year-old that's a Risser 3 and they have a 22-degree curve. You know, it's not a bracing curve, it's not a huge curve. They were diagnosed recently, so they're kind of older. They're, you know, you have to think about, okay, is this curve going to progress or is it not going to progress based on their growth potential? If it's a male, we can't really rely on Risser for that. We would need to go to Sanders because males tend to grow a lot longer. And so we have to take all those things into account. If you are diagnosed with scoliosis and you have a curve that you're worried about, you can kind of look at those 4 things and see what your risk of progression is. If you're a parent of a child who has scoliosis and you're wondering if they need to be treated, you can look at those things. Are they younger? Do they have a bigger curve? Do they have a significant family history? Do they have a lot of growth potential? Look at those things, and if the risk is higher, then we want to treat it. If there's relatively no risk of progression, then we can probably monitor that and not treat it. So a lot of times I have parents ask, you know, left untreated, what will happen with this curve? The problem is I don't know. I've seen curves that technically were done growing and they progressed, and I've seen curves that were supposed to progress that didn't seem to progress. So we can't tell 100% what the future holds with this, but we look at where the risks are, and would I rather treat a curve that isn't going to progress and have it not progress, or would I rather not treat a curve that has a higher risk of progression and see it progress? I wouldn't want to do that. I would rather treat them even if they're not going to progress, if they have a higher risk of progression. Does that make sense? That's kind of confusing. I'd rather treat and not need it than not treat and wish we had. There we go. That's a little bit better. This is something that we see every day, and we do this calculation based on risk every day with our patients to try and make sure that that curve is held stable and steady or reduced as much as possible. We can also think about bracing in those same ways. Does someone need to be braced? Well, what's the risk of progression? So thanks for listening to me ramble and rant about, I guess not a rant, more ramble about those 4 things, but look at age at diagnosis, Cobb at diagnosis, their growth potential, and their family history, and that'll give you a good idea on if you need to be treated. If in doubt, come in for a free consultation. We'll do a consultation with you and tell you what we think. And we'll be honest, if we feel like you need to be treated because you have a higher risk, then we'll tell you that. If you don't need to be treated, then we'll also tell you that. So thanks for watching. I hope this was helpful. And if you have questions, leave them in the comments. Thanks.